Respiratory, Vascular, and Other Disorders of Sleep, PSG 112, Unit 2, Part 7. Just kidding, it's me. Let's talk about some of the disorders that don't necessarily come from sleep, but it's still important to sleep technology. Respiratory disorders, talking about the lungs and gas exchange. Gas is oxygen and carbon dioxide. A restrictive disorder is the inability to expand the lungs to get the needed volume to properly ventilate. And these are less common than obstructive respiratory disorders. For restriction, we're talking about something that is not allowing the muscles of the respiratory drive to work. This could be cystic fibrosis, where there is an actual blockage of the secretions as well. Obstructive disorders are much more common, and obstructive disorders means some part of the airway is blocked by something or some mechanism. COPD, or chronic obstructive pulmonary disease, is a leading cause of death in the United States. It's caused mostly by smoking, but it can also be caused by working or living in a poorly ventilated environment with a lot of particulates or smoke in the air. Particulates are tiny little things that you can inhale. COPD can cause the airway to narrow, cause thick secretions and mucus to hang out in the airway, causing the physical obstruction as well as at the alveolar level, where the smallest air sacs exchange the gas with capillaries. COPD can be associated with bronchitis, which is the illness that involves the bronchial tubes, and those are the tubes that lead to the lungs. When you break the word down, we know what bronch is, and itis means inflammation. So here the tubes are literally swollen to the point that it's difficult to move air in and out. Bronchitis can be acute, like with a common respiratory illness like a cold or a flu, or chronic, like what smokers get, and that's long-term. Bronchitis can be accompanied with a cough, shortness of breath, or chest pain. If you cough long or hard enough, you can actually fracture your ribs. Just from coughing. There are many things that cause inflamed bronchioles, including smoking or long-term exposure to fumes or pollution. Asthma is a condition that can affect young people and some older people, although a lot of children tend to grow out of their asthma. Asthma describes a condition in which the muscles of the bronchial walls contract, called bronchospasm, in response to an allergen or some other foreign agent like chemical fumes. They're closing everything up, trying to keep whatever toxic is, or whatever the body thinks is toxic, out. Asthma is not a spontaneous condition as far as people catching it, but it is managed with breathing treatments like albuterol, which are bronchodilators. People are usually most familiar with asthma attacks, where a person might be introduced to an irritant and might experience difficulty breathing soon after, requiring a rescue inhaler of typically albuterol. Sleep-related hypoventilation is a condition where the patient's respiratory drive is insufficient to maintain breathing during sleep. It can be caused by neuromuscular disease, in which a patient does not have any muscular control over the diaphragm or intercostal muscles. Both are the muscles that allow breathing to occur. It could also be caused by obesity. The lungs have too much weight on top of them to properly inflate. But that would be more specifically obesity-related hypoventilation. Some genetic diseases like congenital central hypoventilation syndrome, also known as Ondine's curse, is a problem with central hypopneas which can be translated into hypoventilation. Some drugs like narcotics can also cause hypoventilation. To diagnose a patient with sleep-related hypoventilation, you must record their capnography, or their CO2. CO2 is what drives the respiratory system. When there's too much CO2, the lungs work hard to get rid of it and breathe it off. Hypoventilators take small and slow breaths that are inadequate, causing the patient to arouse. COPD, while awake, is enough. But if you couple that, and it's really bad when you're asleep, but if you couple that with obstructive sleep apnea, the oxygen desaturations and CO2 retention, or how much CO2 they keep in their lungs, will be much worse. When treating COPD, you have to remove the irritants, which would involve the complete cessation of smoking and the total removal of poor air quality in their environment. In the worst case, remove the patient from the environment. Non-invasive ventilation, or NIV, means any kind of PAP therapy, CPAP, AutoPAP, bilevel, and ASV. You might even see the full abbreviation for NIPPV. NIPPV is non-invasive positive pressure ventilation. Non-invasive means we're not sticking you with anything, nothing's going inside your body. And positive pressure ventilation, we're using air to pressurize the lungs. And that's one of the most important white papers you should read from the AASM regarding PAP titrations is on NIPPV. Sometimes the patient only needs additional CO2 while sleeping, in which case they could just have that. Otherwise, they can put O2 on an NIPPV treatment. All these treatments are secondary preventions to keep the COPD from getting worse. The primary prevention would have been to avoid smoking altogether and dangerous breathing environments like coal mines and dangerous chemical labs. Cardiovascular, when you break it down, becomes heart and blood vessels. When some of these things can actually be caused by sleep apnea. A myocardial infarction, or a case where the myocardial tissue, myo meaning muscle tissue, cardial meaning heart, that's when it doesn't get adequate blood supply due to a blockage of the coronary artery. Remember, artery means bringing oxygenated blood. And after the coronary artery is not giving blood to the heart anymore, it's unable to pump blood to the body. Blockages are typically from fatty deposits inside the blood vessels. Inadequate blood supply to a body is also called ischemia. These can be major or minor. Some people don't even get the symptoms of minor heart attacks and don't even realize it until they go to a doctor or do specific testing. A stroke is a crisis when either part or the whole brain does not receive an adequate blood supply. There are two different kinds of strokes, ischemic and hemorrhagic. An ischemic stroke is when a fatty deposit in a blood vessel becomes dislodged and moves to a part of the brain and blocks that blood vessel. Wherever the part of the brain isn't getting blood is what part of the body's functionality becomes impaired. Remember, ischemic means blood is not getting somewhere. It's a lack of blood. A hemorrhagic stroke is when a blood vessel in the brain breaks. This can cause a bunch of problems. The first being the part of the brain where the vessel is broken and no longer getting a blood supply. And the second problem is the constantly increasing pressure of the rogue blood cell that's now causing a lot of pressure against the soft tissue of the brain. Hemorrhagic strokes are less common than ischemic strokes, and they're typically caused by injury to the head. Boxers and other athletes who get head injuries like footballers and hockey players can suffer hemorrhagic strokes. Heart failure is a condition where the cardiac muscle tissue is no longer strong enough to pump an adequate blood supply to the rest of the body. It can be caused by coronary artery disease, high blood pressure, or an irregular heartbeat. Patients who have heart failure may experience shortness of breath, weakness, fainting, and chest pain. Cardiac arrhythmias are where the electrical current of the heart travels through the cardiac cells in a route that is not the normal pathway. This is not to be confused with the blood flow. This is the electrical current. The electrical current usually starts with the pacemaker cell node, or the SA node, the sinoatrial node, and it travels through so that the valves open and close and the chambers pump properly. Probably the most common arrhythmias are premature ventricular contractions or premature atrial contractions, commonly known as PVCs and PACs respectively. There are many different arrhythmias, and it can take a long time to get to know how to read each one. However, if you can describe the characteristics of a normal heartbeat and how they differ from what you see in a particular PSG, you can provide some great insight as far as the EKG goes. Let's talk about arrhythmias a little bit because you, as a sleep technologist, can detect these and particularly save a life. What is the normal heartbeat called? NSR, or normal sinus rhythm. Why is it sinus rhythm? Because the rhythm is kept by the sinoatrial node. You may hear the term ectopic beats. Ectopic or ectopic beats are beats that are not originated by the pacemaker or the SA node. So let's see. We've got, this appears to be normal sinus rhythm, just normal heartbeat. Normal heartbeat. Looks like a normal heartbeat here. Ectopic beats are beats that are not originated by the pacemaker. So those would include PVCs or premature ventricular contractions. And those are caused by an irritated cardiac cell. Remember that heart tissue is made up of just a bunch of muscle cells, which most are capable of starting a heartbeat. So if one gets irritable enough and feels like it can start a heartbeat. PVCs can be pretty common, especially with caffeine usage, dehydration, high anxiety, and sleep deprivation. This is a couplet. These are two PVCs put together. Here's one PVC, there's another PVC. Couplets, and these are two PVCs that happen one right after the other. I don't have a picture of Bigimini, but that's when one PVC would happen, then a normal beat, then a PVC, then a normal beat, and that happens over and over. Multifocal PVCs are PVCs that are happening in more than one location, two focuses or foci. This is one PVC, this is another PVC, but they look different, and they are different. They're coming from two different heart cells, multifocal. The ventricular part is because the cell that is causing the irregular beat is in the ventricles somewhere. We can tell a premature beat is in the ventricles or the atria by the way the EKG looks. A PVC is typically going to be wide and bizarre and really big sometimes compared to a normal beat. A PAC looks just like a normal beat. I just realized I didn't have my laser on, so I'll talk about these a little bit too. A PAC looks like a normal beat, but it occurs too quickly, and sometimes the P and T waves can intermingle, and you can't tell which is which. Heartbeats look different depending on where you put the EKG leads. Each location that you put them on provides a different view, kind of like a different camera angle, and the electrical impulses can be bigger or smaller. All right, here's a PVC that's wide and bizarre. It's very big. Another PVC. These are multifocal PVCs. Here's one PVC, another PVC. Is ventricular because it's coming from the ventricles somewhere. Here's a couplet. There's one PVC right after another. Here, let's see. PACs look like normal tiny heartbeats. SVT, which is supra, S-U-P-R-A, supraventricular tachycardia. You've got that, let's see, or ventricular tachycardia. SVT, supraventricular, and then ventricular tachycardia. So here's ventricular tachycardia. These are all PVCs, and this is when you put the taco down and make sure the patient is okay. I recorded all these with my time in Raleigh. This is SVT. See how the normal heartbeat is, boop, 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 and then all of a sudden, if you look hard enough, you see the PQRS T wave, and then here you just have maybe a PQRS but then that's really close to that one, so you can't really tell sometimes which the P and the T waves are. Like I said, PVCs are wide and bizarre. Usually has to be 100 beats per minute, but sometimes you'll see that some books are saying if there are just 3 PVCs right after another, that qualifies for a run of ventricular tachycardia. And ventricular tachycardia is potentially life-threatening. The only reason I didn't activate EMS for this particular rhythm here that I recorded was because the patient's oxygen was normal, and it was fine, and I went in and I could still feel a pulse on the ankle. It did last for a good 5 minutes or so, but I probably didn't breathe for that entire time. But the patient did eventually revert back into normal sinus rhythm, or NSR. Other common arrhythmias you may see are atrial fibrillation, heart blocks, which are electrical blocks and not physical blocks to the blood flow, and sinus arrhythmia, which is when the respiratory system changes the heart rate whether a person is breathing in or out. And this is a normal variant and is common in healthy individuals. The reason poor sleep causes cardiovascular issues is partly due to the reaction of the autonomic nervous system. When you sleep, the parasympathetic system is taking care of normal functions like digesting nutrients, resting the body, and tinkering with the brain. If you begin to have instances where you don't breathe or an apnea, your body literally freaks out and goes into sympathetic mode, which means fight, flight, or freeze. It's activated when biological data receptors detect an excess of CO2 and wakes the patient up. Normal sleep should be parasympathetic time, but if there are sleep-related breathing disorders, there's bound to be more sympathetic activity, which is really hard on the body. It increases the adrenaline response, as well as cortisol, which includes fat deposits in the midsection of the body. Hypertension is high blood pressure. Blood pressure is not something we normally monitor as the patient is asleep, but it's a good idea to take it before they fall asleep and when they wake up. When you fall asleep, the blood pressure should fall as well. But if you're continually waking up due to sleep-related breathing disorders, you're continually causing the pressure to come back up. This can be an incredible strain on the heart, especially when it is supposed to be at rest. High blood pressure occurs when the volume of blood is too great and the heart is pumping hard against the walls of the blood vessels. Hypertension can also be caused by genetics, or not exercising enough, or too much salt in your diet. Salt retains water, it holds on to it, and can make the blood volume increase. We've talked about heart failure and the heart's muscle not being strong enough to pump. Because of this, the body starts to change to allow for better cardiac output or blood flow, and these come in the form of not breathing or central apneas. Cheyne-Stokes respirations, or CSR, is another respiratory pattern that is seen with heart failure patients. It's the body's way of protecting the heart from more damage. We've spoken about cardiac arrhythmias, and those are all about the electrical current flow through the heart. If the heart is about 100 beats per minute, or BPM, that is too fast while asleep and is considered tachycardia. I personally have had a patient with a normal sinus rhythm, but it was about 100 beats per minute for the whole night. Any kind of tachycardia during sleep is not good, sinus or ventricular. Always document when you think you see it. The 2 most common arrhythmias associated with sleep apnea is atrial fibrillation and ventricular tachycardia. The diaphragm is the primary part of the anatomy that facilitates breathing. The intercostal muscles between the ribs also have some to do with it. When the diaphragm is expanded, the lungs open and fill with air. When the diaphragm relaxes, air escapes through the lungs because the pressure inside the lungs is greater than the outside environment. If you think about it, you really don't force air out when you're breathing normally. It just kind of falls out slowly. The lungs are 2 separate entities. One lobe is actually bigger than the other, and they can work independently of each other. People can be born with one lung or lose one to illness or injury and still lead productive lives on one lung. However, the diaphragm is activated by the brain through nerves, and if that nerve chain is broken, then the diaphragm doesn't have anything telling it to move. This can happen in spinal cord injuries where the patient is paralyzed, or it can occur with nervous system degenerative diseases like multiple sclerosis, where the patient slowly loses muscle ability voluntarily and involuntarily. GERD, or gastroesophageal reflux, is also known by heartburn. This is caused by stomach acid being pushed back up through the esophagus, causing a burning sensation. This can happen if a person eats too much spicy or sweet or salty foods or has an excess of stomach acid already. It can also occur from sleep apnea. When the airway is closed, the body works much harder to breathe, and that can squeeze the stomach, causing GERD to occur. A paradoxical effort is when the patient's chest is moving the opposite direction of the abdomen, like a balloon. When you squeeze one side, the air doesn't escape, so it inflates out the other side. Fibromyalgia is generalized pain, just pain all over, or sensitivity to touch, tenderness of the muscles. Myalgia means muscle pain. You can have myalgias during COVID or the flu. My leg muscles are super sore, and I have to keep them moving to keep them from going crazy when I get that kind of flu. We're not sure of the cause. Usually when there's pain, there's inflammation. But with fibromyalgia, there is no inflammation. Pain is one thing that the brain's neuroplasticity, or the ability to get used to things, can't control very well. When there's constant and chronic pain, the brain can't shake that, and all the energy that your body has goes towards acknowledging that pain. That can be super detrimental to sleep. It's very hard to sleep through pain, and you'll see that in the sleep lab. Because of the lack of sleep and all the energy going to pain management, the patient's mood, appetite, memory, and all sorts of other things can deteriorate. Tension headaches are also a common symptom. There are treatments, but no cures for fibromyalgia. Antidepressants can be prescribed as well as narcotics, but narcotics only mask the symptoms and can be abused easily. Cystic fibrosis is a chronic disease that frequently, at least in the past, killed most of its victims early in life. Due to a defective gene, there is a sodium ion channel dysfunction that affects the lungs and several organs. The lungs are unable to clear thick and sticky secretions, which obstructs alveoli, the tubes and ducts and passageways, pancreas included. Not only does it obstruct, it can also catch and hold on to infectious agents like disease and all sorts of things. CF patients are on multiple medications and breathing treatments. One of those treatments is a percussive vest which vibrates vigorously on the patient's chest and back to try and clear these secretions physically. And before the vest was invented, patients would have someone like their parents clap on their back. These treatments must become an established routine for the patient to have the best chance for the best health they can get. It affects roughly 1 in every 3,000 pregnancies, and both parents have to carry the defective gene. Proactive parents can get genetic offspring tests that will indicate if certain genes are carried that are known to cause chronic illness like cystic fibrosis. CF treatments have come leaps and bounds in recent history. Ultimately, most patients need transplants, but in 2006, the average life expectancy had risen to 26 years old. Today, CF patients average 66 years. But as cystic fibrosis awareness proponents will tell you, we won't stop working until CF stands for Cure Found. Okay, that's some respiratory stuff for you. We'll come at you next time with the last part in this unit.